Hello, my name is Shelly Weizman. I'm an attorney and adjunct law professor at Georgetown University in Washington, D.C. I teach courses at Georgetown Law School and also in our new master's program in addiction policy and practice, which is at the Graduate School of Arts and Sciences at Georgetown. I came to Georgetown from working in state government in New York, where I worked for the governor. I oversaw New York's policy and operations for substance use disorder, mental health, and disabilities, including the delivery of behavioral health services in New York's prison system. And that's one of the topics that we're going to focus on today. I'm with the Addiction and Public Policy Initiative at the O'Neill Institute for National and Global Health Law. We are a health policy think tank at Georgetown University Law Center in Washington, D.C. And our main area of focus is developing strategies and tools to translate research and science into actionable and meaningful public policy that has to do with substance use disorders, addiction, and recovery. I'm also a person in long-term recovery. This is my little family. That's my husband. He's an Army officer. And that's our little one, Jack. And I wouldn't be here today talking to all of you, and this happy family in this picture wouldn't be here either if it weren't for the opportunities I've been given to live and thrive. When I was arrested, I was offered treatment instead of incarceration, which helped me when I went to get a job, get a student loan, apply to law school, be admitted to practice law. I had good insurance, so I could get the help I needed, and my family could too. I had access to recovery supports, to peer supports, not just once or twice, but for many years. Today, I've been in recovery for almost 25 years, and I get to live my dreams, and we all deserve that. And it starts with a change in mindset of how we approach this issue, followed by real, meaningful, and lasting changes in policy and practice. And I know that the people who are at home watching or there in person are all champions for change, and I'm honored to be with you today. So back to our focus at Georgetown on increasing access to evidence-based treatment. We focus on this because, as of course many of you know, we are in a crisis. And it's a public health crisis. Even before COVID-19, life expectancy was on the decline. And this is the longest decline in life expectancy that we've seen in 100 years. And it has become so severe that it is now a national security issue. So we are in a true multi-level crisis. So I think people, for better or worse, recognize what this is. This is the stadium where the Dallas Cowboys play. It is one of the largest, I think it's actually the largest professional sports stadium in the country. And when I began using this slide a few years ago, this was the number of people that were dying of a drug-related overdose per year. And at the time, this is about 85 to 88,000 people that could fill this stadium. Last year, it was, we were spilling out of this stadium over 108,000 overdose deaths. And that's over 1 million deaths since the CDC began tracking this in 1999. Right now, we're seeing an explosion of overdoses, morbidity and mortality, primarily due to illicit fentanyl. It's also increasing mortality for Black, Hispanic, and Native American populations. And we're also seeing that coupled with disparities in access to care across communities, notably rural communities, tribal communities, and of course, what we're talking about today, jails and prisons. So I think also many people recognize the image on this slide. this is where we were, right? In the 80s and the 90s, this is your brain on drugs, an egg cracked into a pan. This was one of the primary strategies in our country for addressing this, right? Just say no. So I think a lot of people recognize this and remember this. And for better or worse, this is where we were several decades ago. But now we are in a much, much different place. This is what we're in today, right? The pan has an egg in it cracked, but the whole kitchen's on fire. And in fact, probably the whole house is on fire. So where are we and what can we do about this? We're going to cover a few things today. One is the current state of the nation's addiction crisis. Then I'm going to drill down on a few focused areas for policy reform, one of which is a targeted strategy focused on what we call the criminal legal system. A lot of people with mental health conditions, with substance use disorders, end up in our country's jails and prisons. In fact, it would be safe to say that jails and prisons are really on the front lines of this crisis. There are varying data about the percentage of people who have a substance use disorder that are incarcerated. There are some studies that say it's as low as like 63%, others as high as 80% or more. Whatever the exact percentage, I think we can all agree that we're talking about a very large number of people here. Because of this, we've seen communities across the country leading the charge in addressing this issue in carceral settings. And there's really some strong innovation, some great work going on across the country, and I'm going to highlight some of that too. And there are an increasing array of policy strategies, of clinical strategies to really move the dial on these issues. So I'm going to cover that today, but first I'm going to talk a little bit about how we got here. So this is a slide about what we're calling the waves of the opioid epidemic or the overdose crisis. And there's, these data are presented in a lot of different ways. I used to use a slide that was like a graph, kind of just showing the jump. But I really like this slide here because this illustrates better where we are. It's really a spiral, starting out with prescription opioids, leading to heroin, and now fentanyl. Some would say we're in a fourth wave, which is connected to fentanyl, but it's about illicit fentanyl being in just consuming the drug supply, not just heroin, but also methamphetamines and other substances. And we're spiraling out here. So this is where we are right now. And on the kind of other side of the coin, we're in a situation where a lot of people need help, need treatment, but not a lot of people get it. Right here we see this is a graphic that's actually a few years old. 10% of people who need help get treatment. It may be more like 12% now. But I think that is still, again, folks would agree that's a very small percentage of the people who get treatment that actually need it, people with substance use disorder. What happens to everybody else? Well, either they become part of the mortality statistics that I mentioned earlier, part of filling that stadium, or they end up in the correctional system, right? This is a chart showing just the explosion of people who are incarcerated in prisons and jails for drug offenses. And often, even if they end up in the correctional system, they still die of an overdose or a drug-related death. The Bureau of Justice Statistics at the U.S. Department of Justice has been tracking deaths in jail custody for the past 20 years or so. And what they found are a number of trends. One is that deaths in jail custody are increasing across all causes overall. Deaths due to drug or alcohol intoxication in jails increased about 19% from 2017 to 2018. That's some of the latest statistics available. and have more than quadrupled between 2000 and 2018. In the latest data available from 2019, 2018, suicide was the leading cause of death in jails. And about 40% of deaths from all causes occurred within the first 7 days of admission to jail. So the first week somebody is in jail, 40% of deaths occur. So when we think about where to target resources, target strategies, it's pretty clear first part of when somebody is incarcerated to avoid unnecessary mortality. And we also know that about 77% of everyone who died in local jails in 2019, again, the latest numbers, were not convicted of a crime at the time of their death. So not only are these folks dying in custody, they have not been convicted of a crime. And 42% of unconvicted persons held in local jails who died in that kind of 20-year span, starting in the year 2000, died of either suicide or drug or alcohol intoxication. So, we're really seeing some troubling trends about deaths in custody. Not only that, research shows that people also die of overdoses right after being released. Upon release from incarceration, people are between 10 and 40 times more likely to die of an opioid-involved overdose than the general population, especially within that first few weeks after release. And even if people don't die, they face significant collateral consequences of incarceration or justice system involvement. Barriers to housing, employment, education, challenges with parenting, with rebuilding a life. And we know what helps people find sustained recovery: stable housing, economic and social mobility, community, a sense of purpose and belonging. And those are the very things that are harder to obtain once somebody has been justice involved. Something is not working with the way we have been doing things. There's a clear human cost to this approach, and we can see from these faces here. There's also a financial cost. When people die in custody of a correctional facility, for example, there are lawsuits, and often very large settlements, as you can see here. And we actually drilled down into that. We did some original research at the O'Neill Institute, and it's going to be published in January in a series of reports. And we looked at all the litigation that has been brought against jails for deaths in jail custody over a 5-year period. So this was 2015 to 2020. All the cases, civil litigation involving deaths in custody. And what we found was jails paid out over $256 million in settlements and judgments. 84 million of that were lawsuits for people who died in custody related to drug withdrawal, overdose, or substance-related issues. We found, just like the Bureau of Justice Statistics found, that in these cases, suicide was the leading cause of death, which accounted for the claims in 35% of the cases reviewed. And drug-related deaths, including overdoses and deaths related to complications from withdrawal, this includes alcohol too, accounted for 19% of the lawsuits filed. Additionally, we found that in many of the cases where the cause of death was not directly drug-related, there were substances involved or a history of substance use disorder. So, for example, so the number is 32%. 32% of cases included facts that indicated that the person that passed had consumed illicit substances or alcohol prior to intake, or had a history of substance use disorder, which may have contributed to the death. So one example of this is in cases involving a death resulting from use of force by a correctional officer, there was evidence of substance use prior to incarceration alleged in 31% of the cases. So even though the death was not directly drug-related, there were substances involved in almost a third of those cases. In suicide deaths, facts suggesting pain or discomfort due to withdrawal were present in 20% of those cases. So what we see from our research and from the Bureau of Justice Statistics data is not only is there a significant increase in substance-related deaths, there's an increase in deaths from all causes in jails, and many of those deaths are related to substance use or withdrawal. We also found what the Bureau of Justice Statistics found about when people die in custody. A quarter of in-custody deaths occurred within the first 36 hours after arrest in the cases we reviewed. A quarter of the deaths in the first day and a half. Very significant. And the median number of days between the date of arrest and death for all causes was 5 days. The most common cause of death during the first 24 hours in custody: suicide, withdrawal, and overdose. So again, we can think about policy solutions here to reduce substance-related deaths, really to be targeted at that very first 24 hours, week that people are incarcerated. This is a slide about the economic costs of the overdose crisis and our current approach. In addition to the human cost to individuals and families and financial cost to our systems, there is a spiraling impact on the economy overall. And of course, there's cost to our children. We see the generational effects of this every day, including significant increases in foster care involvement. So, what do we do about all of this? Well, there is a real movement now towards recognizing that we are in a burning building, and a new approach, a different approach, is absolutely necessary if we're going to stem the tide. This new approach is a public health approach that prioritizes evidence-based treatment versus a punitive approach, which prioritizes punishment and surveillance. It's litigation, legislation, and policy guidance as vehicles for reform. And it's about building recovery capital, those social determinants of health, things like housing, employment, community, and purpose. Part of this new approach is to target the people who are among the highest risk. That is people who are justice involved. And there are a few other populations too, including women postpartum. But we're talking today, that could be a whole other presentation, an important one, but we're going to focus on people who are justice involved. So why a targeted response here? Not only are these folks among the highest risk, the correctional system and the court system have traditionally been involved in the response to addiction, but they are also a separate system from the traditional healthcare and treatment system. And they offer a key intervention point for people with substance use disorder. And like we talked about, people in these systems are at a significantly higher risk of overdose and death. So what does this look like? It looks like many things. These are some examples on this slide. Immediate access to treatment at appropriate levels of care. And we're not just talking about treatment behind the walls or when somebody is incarcerated. We're talking about across the board in the community. No wrong door, single, access. When somebody needs it, we know that there's a window of time, a window of willingness, right? When somebody wants help and is ready to get it, and the system needs to be there to meet somebody, not with hoops to jump through, a million referrals and no answer, and on and on. We need immediate access to treatment at the right level of care at the right time. Access to medications for opioid use disorder, also sometimes referred to as medication-assisted treatment. And what we're talking about there is specifically methadone and buprenorphine, also known sometimes by the brand name Suboxone. Studies show again and again and again, over and over and over, that treatment with medications for people with opioid use disorder significantly reduces the risk of overdose and death. And I think we have a few slides about that later on, some studies that really found that, not that counseling's not important, not that mutual support's not important. It is important. But when we're talking about targeting that overdose risk, these medications, those two medications in particular, methadone and buprenorphine, significantly reduce somebody's risk of overdose. Talking about family-friendly treatment with wraparound support, long-term support, diversion from the criminal justice system entirely, or deflection, meaning pre-arrest, something doesn't even go on somebody's record. Withdrawal management in jails, we talked about that critical first 24 hours and first week, and support versus surveillance. So here's a quote to the right of the slide by Sheriff Apple, who's the sheriff in Albany County, New York. This is about medications for opioid use disorder being provided in the jail in Albany County. He said, "I didn't believe in it, but we were convinced to try it. In the first 3 months, we saw a reduction in diversion and recidivism, and it was saving lives. It's a no-brainer." So Sheriff Apple, actually, first time I went to see him was when I was in the governor's office in New York. And I asked him about methadone and buprenorphine, and he said, "No way, we're not going to be doing that here. I don't think so." But sure enough, he was convinced by the advocacy community and by the evidence that he had to do it. And he did, and people just stopped coming back to jail because it was the same people rotating in and out. And once they were given treatment, the treatment meaning the medication, they stopped going back to jail. And he actually had to decommission 100 jail cells, and he turned them into transitional housing for people who didn't have anywhere to go once they were leaving jail. And for anyone that spent any time in upstate New York, you know, it's pretty cold in the winter there. So having some options for transitional housing while somebody gets up on their feet is really critical. And so this is the kind of thing that happens when an evidence-based, a public health approach is implemented. So a public health approach means following the science. This is the study I referenced. This looked at 6 different treatment pathways for opioid use disorder, including residential, outpatient, and some other options, and then buprenorphine and methadone. And only treatment with buprenorphine and methadone was associated with reduced risk of overdose. So pretty significant study to show that, yes, you know, I would agree, you can't always just kind of throw medication at somebody and think, all right, their lives are immediately going to be all better. People need counseling support if they want it. But if we're talking about reducing the risk of overdose, it's these 2 medications. That is what the science tells us. This is another chart about methadone and medications for opioid use disorder in correctional settings. It's working in reducing deaths. And this is what, this is what we're seeing, that where this happens, it's working. So what we're also starting to see is litigation being used as a vehicle to spur these reforms. There are a number of federal and state claims that can be brought, that have been brought against a variety of defendants. That could include a county, a state, a jail, a prison, a sheriff, even the correctional officers and medical staff that's working in the facility. Federal constitutional claims, 8th Amendment violation as applied to state and local correctional facilities using the 14th Amendment. That's cruel and unusual punishment. There's a seminal Supreme Court case that says the basics are that you can't deny medical treatment. You can't be deliberately indifferent to somebody's medical needs. That amounts to cruel and unusual punishment under the 8th Amendment. And in a lot of the cases we're starting to see, they're about applying that to treatment for substance use disorders, specifically medications for opioid use disorder in jails and prisons. State constitutional claims, we have the Americans with Disabilities Act and the Rehabilitation Act. These laws protect people with disabilities from discrimination, and that includes people with substance use disorders, people who are in recovery, and it includes access to treatment and medications when somebody is entering a correctional setting. CRIPA, which is the Civil Rights of Institutionalized Persons Act. It's used by the Department of Justice to bring cases against correctional settings and other types of settings. The Civil Rights Act, I skipped that, sorry, Section 1983. This is where most of the cases that we looked at in our study about deaths in jail custody that were brought by the estates of the people that had passed were brought under the Civil Rights Act. State tort law that can include things like medical malpractice. And then we're also seeing some criminal cases, criminal liability for people working in correctional settings, denying medical care and treatment to people with substance use disorder. So in a number of states, New York and Massachusetts, seeing these cases is motivating and has motivated state leaders, county leaders to take action. And we're seeing this play out across the country now. Many of the cases we reviewed in our study involved a death in jail custody, and many were settled out of court. There has been a movement over the past few years to address these issues before a death might occur, in the context of opioid use disorder in particular. These cases request injunctive relief before the death occurs or might occur or injury might occur. So that means they ask the court to step in and order the jail to provide them with a medication that they're already on, methadone or buprenorphine. So what that looks like is somebody knows they're going to go to jail, that they have a sentence or a date certain, and they file a motion asking the court to require the jail or prison to provide them with a medication that they're already using, methadone or buprenorphine. And in a lot of these cases, the court looks at all the evidence. They look at the likelihood that the person's going to be successful in their claims. Usually these are Eighth Amendment claims or Americans with Disabilities Act claims, or both. And they agree with the person. They order the jail or the facility to provide them with their medication. And what we're seeing is these cases, which have been in a number of states across the country, Massachusetts, Maine, New York, Washington State, a federal prison in Kansas, and a number of other states. These cases have spurred reform in jails across the country, either because they were class actions that required, mostly through a settlement, for the jail to provide medications to everyone that needed them, or because they spurred statewide action through legislation, through an executive order, or through funding, or a combination. So, like, for example, in Maine, the governor did an executive order where over a period of years, all the prisons in the entire state would provide methadone and buprenorphine to people who are incarcerated. So in recent years, at least 31 states have issued these executive orders or taken administrative action, passed legislation, established agency policies governing substance use disorder treatment for people who are incarcerated. And at least 24 bills, legislative bills, concerning specifically access to medications for opioid use disorder in jails or prisons have been enacted across 18 states. So we're seeing a huge shift. And this looks different in different states. In Rhode Island, there was an action by the governor to say, all right, we're going to start doing this in our facilities. And what they actually saw was a 61% reduction in overdose deaths from people who were leaving incarceration. And that led to a 12% reduction in the overdose rate of the state overall. So this really had a connection from people who were released from jail or prison and died of an overdose to the overall overdose numbers in the state. In Massachusetts, there has been legislation passed in tandem with several lawsuits. Same in Washington state. We talked about Maine, and it's now actually starting to ramp up in the jails. And there have been some lawsuits in the jails in Maine as well. And we're seeing facilities in places like North Dakota, Indiana, North Carolina, Illinois, Pennsylvania, Arizona, and California start to ramp up and do this. And a number of states are incentivizing this with funding. New Jersey, for example, Connecticut, Colorado, and other states have given significant funding to get this off the ground. And it's also accelerating with federal funding as well as federal guidance. So what you see here in this slide, the first part is guidance from the Bureau of Justice Assistance, which is part of the Department of Justice, on withdrawal management in jails and about legal liability for jails that fail to provide adequate substance use withdrawal, including alcohol. And this is something that we worked on at the O'Neill Institute for the Justice Department. On the bottom of this slide, this is a report that we issued in 2021, which gave kind of like a 50-state snapshot in time of what access to medications for opioid use disorder looked like in jails and prisons across the country, litigation, legislation, and policies. And we're in the process of doing an update to that because this is moving so quickly and accelerating so quickly. And this isn't just about withdrawal. It's not just about medications. It's also about an acceleration and an increase of robust programming for people while they're incarcerated. This often involves programming and peer support. In New Jersey, for example, there's a really robust reentry support program with peers who were formerly incarcerated who get connected to people when they're upon reentry. Even in places like rural Virginia, you're seeing people who are currently incarcerated being trained during their incarceration to become peers. So we're really starting to see a lot of facilities and state leaders and county leaders kind of start to see that this is what's needed. And of course, none of this is done in a vacuum, right? We have tons of other reforms that are under discussion, under development. One is what's referred to as Medicaid behind the walls. So Medicaid, by federal law, cannot be used to pay for while somebody is incarcerated, to pay for healthcare while somebody's incarcerated. And it's called the inmate exclusion. That's what it's referred to as. Well, there's an effort in Congress to expand access to Medicaid in different iterations, but I think the one that has the most traction is to let people get access to Medicaid 30 days before they're released from incarceration. And that way people can start to get connected to community-based providers even before it's time to leave incarceration. We're seeing a lot of methadone reforms under discussion. There are some challenges in getting access to methadone in general, but also in jails and prisons. And there are a lot of reforms under discussion, under development about increasing access. Americans with Disabilities Act guidance that was just released by the Department of Justice that explicitly stated substance use disorder is a disability under the ADA. This is what that means, and specifically that it means people get access to treatment while they're incarcerated. We're seeing statewide legislation requiring, like we've talked about, access to these medications in jails and prisons. And that picture on the bottom, that's a picture of a model state law that we drafted at Georgetown with some other partners for states that want to implement this through legislation. We have a model law about it. We also have a model law about withdrawal management in correctional settings. And then parity implementation. So parity means just at the very basic level that health insurance, including Medicaid, needs to cover mental health and substance use disorder services in no less restrictively than they cover physical health services. So making sure that there's adequate insurance coverage is critical. So these are just some examples of some of the state and national policy reforms under discussion. You know, again, it's going to take a confluence of different strategies to really start to address this. So I've mentioned the new Americans with Disabilities Act guidance from the Department of Justice. This is just a picture of that, a slide of that. It's pretty clear guidance. So it talks about in the guidance that medications such as those used to treat opioid use disorder has to be provided for people. And not only did the Department of Justice issue guidance, they're also taking actions against government entities and private entities that are engaging in discrimination under the Americans with Disabilities Act against people with substance use disorder, opioid use disorder. This is an example of a lawsuit that they brought against the whole court system of Pennsylvania, which in some courts, people were not permitted to take their medication. And there's a series of other actions that the Department of Justice has taken over the last few years in a number of states. So I'm going to finish up by talking about, you know, where the devil's in the details, implementation. We have all of these strategies and tools. Well, how do we do it? And more importantly, or maybe one of the most importantly, how do we pay for it? There are a ton of resources out there for implementation. I'm going to roll through some of them. There are guides and toolkits, shared learning opportunities, technical assistance, making sure to engage key partners, and of course, funding. Here are some examples of guides and toolkits. This is specifically about implementing treatment in jails and prisons. National Sheriff's Association supports this. SAMHSA has a guide. There's a step-by-step toolkit that the National Council for Mental Wellbeing came out with a few years ago. Lots of information out there. And opportunities for shared learning. California Healthcare Foundation, they have rolled out a program in all of the facilities in the state. And there are a lot of opportunities for lessons learned, for best practices. The Opioid Response Network, which is a SAMHSA-funded technical assistance network, they put on a conference a few years ago that was focused on treatment in jails and prisons, and they've got it all on their website, expert talking about what they do, how to do it, step by step. We have published one of our big ideas policy briefs, which has a link to a series of webinars where we have experts talking about this, and also, again, step-by-step policy tools and strategies. This meaning treatment in jails and prisons. There are many opportunities for technical assistance. A few I'll highlight. I mentioned the Opioid Response Network. This is a fabulous resource. And this, by the way, is not just for treatment in jails and prisons. This is a resource for anything related to needs for technical assistance by communities related to substance use disorder. And it's a huge network of experts that will come out to your community, meet with you, bring a team, they'll work with you totally free. It's funded by SAMHSA. All you do is go to their website and click submit a request, and somebody will get back to you. It's an underutilized resource too. So they are just there waiting for you guys to submit a request. So I encourage you to think about, even if it's not this exact issue, if there's something that you need TA around that you want to ramp up or improve, reach out to the opioid response. And importantly, when we are launching this or starting to do it or improve it, to make sure to engage all the key partners. The sheriff has got to be a champion. And the sheriff, there's no better champion than the sheriff. Jail administrator, the medical director, the corrections officer, manager, to get buy-in from their team, having an opioid treatment program or other provider outside the facility. And of course, many jails and prisons utilize third-party health vendors. So like a private health vendor that delivers the healthcare in the jail. So they have to be a part of this too. So we're going to wrap up with a talk about everybody's favorite topic, funding, how to fund this, and many other things that you're trying to do in your community. Federal grants are a big source of funding. There's a big block grants, what it's called. For substance use disorder, it's the SAPTB block grant. And this is from the federal government to every single state, and DC, Puerto Rico, Virgin Islands, all other territories. And that's where a lot of states get their money to fund prevention, treatment, and recovery supports. State opioid response grants, that's what has funded a lot of this work in jails and prisons as well. Additional funding for states and territories, tribal opioid response grants for tribal nations. There are specific grants that fund programming in the criminal justice system. The COSAP grants in particular are through the Department of Justice, Bureau of Justice Assistance. They, and it doesn't just have to be about opioids, it can be about everything. And they do significant funding for innovation, research, implementation, and they encourage researchers and practitioners to kind of come together and deliver evidence-based practices. And then the Matt Padoa grant, similar, increasing access to medications for opioid use disorder. And then, of course, a huge new influx of funding that is coming down the pipeline right now in every single, almost every single state. We're talking about opioid settlement funds. Going to give just a high-level overview. We've got a bunch of different types of lawsuits, the multi-district litigation, which is federal lawsuits brought by local governments and tribal nations. You have state lawsuits brought by state attorneys general against opioid manufacturers, distributors, and retailers. You have bankruptcy cases in the works. That's where Purdue is at right now, and other civil enforcement actions. So you've got a lot going on with opioid litigation against manufacturers, distributors, and retailers. And of course, many people might have heard that there was recently a case settled, big case. So I made this slide before it was settled. It's for master settlement or the global settlement, $26 billion. And this is for states and local government, so mostly counties. And the defendants in this big settlement are Johnson & Johnson and then 3 distributors, McKesson, AmerisourceBergen, and Cardinal Health. So this is a big case, a big settlement, but it's not the only one. This is just some of the defendants. And distributions are happening now and are going to be made over 18 years, an 18-year period of time. And it looks different in different states. In some states, it's the state itself that has the bulk of the settlement, and they're going to get to decide where it goes, maybe with or without input in a formal way from the community. And in some states, the bulk of the money is going to counties. And so it's county leadership that's going to be making the decision about where it goes. So I encourage folks to understand what the landscape looks like in your state, and who's in charge of making decisions. And in the settlement language, there is a list of the priority strategies, and one of the priority strategies, treatment for incarcerated populations. So that includes funding to provide evidence-based treatment and recovery support for people with opioid use disorder, to increase funding for jails to provide treatment, and also for training. So this is definitely a priority strategy, what we've been talking about today. And there are a number of other priority strategies that states and counties are going to be implementing. So the last few slides here are basically just links to many of the resources that I've referenced or that might be helpful to folks who are doing this work. And that's it for my presentation. Here's my contact information. Feel free to reach out, check out our website, email. And it's been an honor and a pleasure to be here with you today. Thank you so much.